Meeting is being recorded.
All right, so Bismillahirrahmanirrahim and Assalamu alaikum everyone. I hope I am audible to all. Can you please confirm if the screen is visible and I am audible?
Yes, Dr. Maria.
All right, so I am Maria Tariq and I am a resident of radiation oncology. We have been conducting these sessions by KIPRO, which is a club for young Pakistani radiation oncologists, since August 2022. This is going to be our third session, and as per the circulated flyer, we are going to discuss a case regarding the role of re-irradiation in head and neck carcinomas. Our panelist for today is Dr. Nadeem Abbasi, who is a clinical professor of radiation oncology at our university hospital. We also have Dr. Fatma Shaukar as a panelist today. She is a consultant radiation oncologist at Tomotherapy Center, JPMC, Karachi. Before we begin, may I please request Dr. Bilal Ahmed to recite a few verses from Holy Quran.
Assalamu alaikum, everyone. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. Translation. Read, O Prophet, in the name of your Lord who created humans from a cleansing cloth. Read, and your Lord is most generous, who taught by the pen, taught humanity what they knew not. صدق الله العظيم.
Right, Jazakallah Bilal. Right, so Dr. Abbasi has some network issues. He will be connecting in a while. So, in the interest of time, we will be starting with our today's discussion. So, this is the case on the screen for you all. A 40-year-old male with good performance status who is a known hypertensive and chain smoker. He's also a known case of squamous cell carcinoma or of right buccal mucosa, for which he had surgery in 2018, and histopath came out to be a pathological T3 and 2 at that time. He completed his post-op adjuvant concurrent chemoradiation therapy in November 2018. His post-radiation scan 3 months after CCRT was clear, and he remained disease-free for a period of 3.5 years. In September 2022, he developed dysphagia, for which FODL was done, and it showed a lesion in the piriform fossa, which was biopsied and was consistent with squamous cell carcinoma. Staging workup was negative for any nodal and distant disease. So as you can see, I have highlighted a few things in this case. I have also put a steric on the staging, which has a reference as mentioned at the end of the slide. The staging workup here is very essential because as per this literature evidence, around 25 to 30% of patients, they are upstage, that is, they are found to have a distant disease when the staging workup is completed for a case who has a recurrent squamous cell carcinoma in a head and neck region. So if we look at the stats of a recurrent or a second primary head and neck cancer after post-op chemo-RT, an incidence of around 16 to 25% of developing a recurrent cancer in head and neck region, and after definitive chemo-RT, an incidence of around 17 to 52% in the head and neck region. These are quite variable figures taken from the evidence as mentioned at the end of the slide. However, if we take a general term, around 30% as a whole, around 30% of the head and neck cancer patient, they recur loco-regionally after getting definitive treatment for their carcinoma in the first course. If we talk about the second primaries and head and neck cancer survivors, there is a risk of around 15 to 20% at 5 years of developing a second primary in the head and neck region. Or if we can say that in long term, the patients who undergo an aggressive multimodality therapy and they become a long term survivors, there is a 40% risk of them developing a second cancer in the same region, that is the head and neck region. Majority of these recurrences, the loco-regional recurrences, are in field. As we can see in this slide, there are different
हाँ बोलो
kind of recurrences.
डबल क्लास होगा
Can you please mute? Can you please mute yourself? Okay. So there are recurrences in the central high dose region, and these are the most common recurrences, which we will see in the upcoming slides with the evidence of literature. The most common recurrences are in the central high dose region. However, there are also recurrences found in the peripheral regions, peripheral high dose regions, in the elective dose regions, in the peripheral elective dose region, and at some other site as well, which are the A, B, C, D, and E as depicted on these figures E, D, A, B, and C. So, is retreating a patient with a recurrent or a second primary necessary? Yes, definitely. It is necessary, as we can see in this table by Ellen Ho. This study was published by Ellen Ho in 2014 in the journal Head and Neck. We can see that a patient who develops recurrence or a second primary, if the patient is untreated, the median survival in months is 3.8. And if that patient is treated by a salvage surgery with or without adjuvant therapy, the median survival rises up to 21.5 months. So this is taken from a paper published by Ellen Ho in 2014. So what are the management options? When we have the scenario of a recurrent or a second primary, the management options are somehow limited. We cannot always incorporate all the modalities subject to the toxicities they may cause or the toxicities, the late toxicities of the previous or the prior therapy which was administered. So salvage surgery whenever possible, followed by re-irradiation in the adjuvant setting, or when the salvage surgery is not possible, a definitive radiation therapy, a definitive re-RT course with or without chemotherapy, if the performance status allows, or if nothing can be done, it is going to be a best supportive care. All right, so there are some factors, some patient factors, some tumor factors, and some treatment related factors that define the choice of treatment. When we talk about the patient factors, age, comorbidities, functional status of the organs, either the organ dysfunction is due to the prior treatment or as a result of toxicity, or is it a late sequela, socioeconomic status of the patient, and the compliance issues. They all play a major role in the patient factors that help the physician or that guide the physician in making the choice of the treatment. Coming towards the tumor factor, the stage of the disease at the time of recurrence, the disease extent at the time of recurrence, the volume of the disease, that is the bulk of the disease, the subsite in which the recurrence has occurred. There are some subsites which perform fairly well even in the recurrent setting, just like NPC. And there are some subsites which do not perform very well in case of recurrence or second primary. Involvement of adjacent structures, just like encasing the internal carotid artery or very extensive infiltration of prevertebral muscles, and the disease-free interval, which is very important, or the sequela of the prior therapy. Maybe the patient is continuously dependent on the PEG tube since he was radiated or treated the last time. Maybe the patient has developed pharyngeal stenosis resulting in continuous dilations. Maybe the patient has developed some laryngeal chondronecrosis. So things like that would also guide or drive our management plan. And then comes the treatment factor. In treatment factor, we have three main categories, which is the 3M. man, machine, and methodology, which describes the expertise, to be exact, and the infrastructure. Now, first we will discuss till now. Any question? All right, so we'll proceed with surgery. Surgery as a salvage modality, as we can see here in this table, the cure rate for patients undergoing salvage surgery was 30%. A patient who doesn't get a chance of having surgery as a salvage modality has an inferior survival to a patient who somehow is a feasible candidate for having salvage surgery. So whenever there is a recurrence, we need to discuss the patient in a site-specific multidisciplinary meeting to decide whether it is a salvageable or non-salvageable disease by surgery. Now coming towards our main discussion today, which is re-irradiation. So what is re-RT? I have taken this definition from a very recent paper which was published earlier this year in April 2022. This is basically an executive summary of the American Radiation Society, who have devised up appropriate use criteria to guide the clinicians involved in the re-irradiation of head and neck cancers. So they have defined re-irradiation as an additional course of RT, which at least partially irradiates the same tissue as the prior course of RT with a biologically meaningful dose. And by this, they mean to say that a dose which is a 2 gray equivalent of at least 45 gray or more to the tissues that have previously received a 2 gray equivalent of at least 45 to 75 grays. Now, there are some prerequisites. First and foremost is a multidisciplinary evaluation by a site-specific team. The team is first going to confirm the recurrence or the second primary histologically. They need to gather the details of the prior treatment received, the number of modalities which were incorporated in the previous course of therapy, the interval from the previous treatment to the treatment that is going to be offered now, radiation therapy delivered previously, the total dose of the radiation therapy, the fields that were used, the technique that was used, and the volumes that were covered with the radiation therapy. Any late sequela of prior therapy, that is, as I already mentioned, any dependence on the PEG tube, like any organ dysfunction. It could be a pharyngeal stenosis, it could even be a fibrosis, neck fibrosis, skin fibrosis, muscular fibrosis occurring. Metastatic status of the patient, as we already discussed in the first slide, there's around 30% of the patient, they are having a distant disease present at the time of recurrence. Then we also need to define at the baseline a treatment intent for the recurrent scenario. And we need to look, as we already discussed, about the options of salvage surgery. Is it possible? Is it feasible? Or is it too risky? When we talk about re-irradiation, there are some major concerns. When a second series of RT is to be given to the same region, the major concern is, can we do it safely with the similar high radiation doses, since we already know that a full dose radiation was delivered previously and the normal tissues have achieved their constraint or they have passed their constraints. When re-RT is considered for a true local recurrence and not for a second primary, which is in the vicinity of the first tumor, how can the same or similar regime be expected to have a curative potential? And if so, what could the mechanisms be? We are not going to go into the biological details today, but just to keep in mind, or just for a quick review, when a bed, when a tumor bed is had a prior treatment, that bed is supposed to be hypoxic, to have accelerated repopulation issues, to be resistant to the therapies being offered. These are some biological features that have to be kept in mind when we are offering re-RT. Therefore, the decision making in the scenario of re-irradiation is very challenging because, as we just discussed, these recurrent second primary tumors are biologically very heterogeneous. These recurrences may be a focal nidus of disease presenting at an earlier stage, that is picked up at an earlier stage, hence signifying the role of a stringent follow-up. And these are curable with salvage surgery with or without the need of an adjuvant RT. The recurrent disease may be infiltrative with a substantial subclinical spread beyond the GTB, which would create a challenge for the radiation oncologist. Variable tumor characteristics may also influence the pattern of failure, that is, it disrupts the lymphatics. That is why probably there is no benefit of electively irradiating the nodal basins. Other tumor related features are the HPV status, because it is a long-term situation then, the primary site of the disease, initial stage of the disease, and the prior treatments that were received. Patient factors, as we also discussed, are very important, and they are also very heterogeneous, because different patients will be having different comorbidities and different treatment related sequelae like PEG tube dependence or substantial laryngeal fibrosis, which would increase the toxicity caused by the Re-RT or the second RT course. So the basic rules for Re-RT is site-specific MDT evaluation of a Re-RT when responded well to the initial course of RT as well, minimize the field overlap as much as possible, avoid prophylactic RT to the regional nodal basins, Re-RT with a total dose of at least 60 gray, use a different or a more conformal or a higher RT modality. Peer review of the RT plans is very crucial. If IGRT is available, it would also allow you to reduce the margins. When there are bigger volumes in Re-RT, the outcomes are not supposed to be good. Now, the biggest question, the patient selection for Re-RT. We cannot just re-irradiate every patient with recurrence. Now, this is a nomogram. Any question till now?
Ji beta, can I add?
Ji, sir.
Okay, this is Dr. Farooq from Shifa. Thank you very much. It's a very important topic, and if you are a head and neck guy, you will encounter these patients every now and then. Now, regarding your first presentation, because I'm driving, so I couldn't stop. This is the only time I could stop, was the incidence of second primary. I heard you said 40%, or you were talking about 40% relapse rate post-radiation?
The second primaries, as per the literature, 15 to 20% risk at 5 years, and in long term, around 40%.
Yeah, I agree. It's about 15% in the first few years. And obviously, if you're still alive, your chance would go up. Agree with that. About your surgery, if you're doing a massive surgery, a morbid surgery for Re-RT, then a negative margin has to be ensured. Any surgery with a positive margins would necessarily ask you to boost that area, and we do not have that luxury to do it. So you should be the first one to say, no, if you can't get a negative margin, we are not going to radiate. So it has to be a negative margin surgery to re-irradiate. This is one. Number two, if you have a patient who had a resurgery that necessitates flap rotation, then we normally say that irradiated tissue has been removed. So you have the luxury of irradiation. And as I understand in Ahan, you have these plastic surgeons who can do this for you. So Re-RT in those vicinities would be fine. Again, you have to keep an eye on the carotid structure, because the rate of carotid rupture is around 40%, and so that is about it. When you talk about Re-RT, I don't know how much dose would you consider as a tumoricidal dose, but nothing below 60 grays tumoricidal. So again, margins, close margins are very important. And 60 gray, imagine if you're re-irradiating the posterior pharyngeal wall, the sphincters of the swallowing area, the osteonecrosis of the mandible, dental issues, and severe fibrosis. These are all, you need to keep them in mind. So Re-RT, yes, we can do it, but these are the major issues you need to look into. Let's see what you have to say about your doses and your volumes.
Thank you so much, sir, for your valuable input. All right, so now continuing with our discussion, there are multiple nomograms which are published in the literature till now.
नहीं नहीं मैंने बहुत सारा खाया बस ये मैं मीठा लेता हूँ जज़ाकल्लाह।
All right. So now continuing with this discussion of nomograms, there are multiple nomograms regarding RE-RT for head and neck cancer in the published literature. This particularly was published in Green Journal in 2014 by Memorial Sloan Kettering. It was a retrospective study, and the N number was 257. The patients had a median prior RT dose of 65 gray, and the median time between the prior and the second course of RT was 32.4 months. The 44% of the patients had salvage surgery, and 67% also had concurrent chemo with the second course of RT. The median re-RT dose was 59.4 gray, and 78% of this re-RT was done using the IMRT technique. Cumulative RT dose of the both RT courses was around 122.4, with a 2-year local regional control rate of 47% and an overall survival of 43%. And this was for a median follow-up of 32.6 months. Now, if we look at this local regional control, univariate and multivariate analysis, as you can see on this slide, I have highlighted some parameters which are very crucial while we are doing patient selection. The stage of the disease, as we already discussed, the initial site of the disease, the performance status of the patient, any existing organ dysfunction, surgery if it is possible or not, and the radiation dose and the technique that you are going to employ for re-RT. Now, coming towards this paper by the Red Journal, IJROBP, it was published in 2018. This again, we are discussing in the context of patient selection, which is still a very poorly defined category when we talk about re-RT. We need to individualize by case-to-case basis, but the literature always supports our clinical practice. So this particular one is famously known as MIRI collaborative. This one again is a retrospective study. Around 412 patients were analyzed for a primary endpoint of overall survival, local regional failure, and distant metastasis, while the secondary one was toxicity. So surgery was done in 47% patient, and definitive re-RT was done in 52% of the patient. A median dose of 60 gray in 33 fractions was administered, and around 80% of the patients, they had it delivered conventionally. The technique was mixed, that is 3D and IMRT both. All the patients with recurrent squam or second primaries in the head and neck region who had received a prior RT volume of at least 40 gray with the radiation technique of 3D or IMRT were eligible to be recruited in this one. And the patients with distant metastases were excluded. The median time between the previous course of RT and the second course of RT was 2.4 years, and the concurrent chemo regimes were platinums and cetuximab. Okay, so now if we look at this, this is a paper. These are basically the salient features of the patients who were included in this MIRI collaborative study, and we can see there the statistically significant results for the patient's stage, for the patient performance status, for any existing organ dysfunction, for the interval between the prior RT and the second course of RT, and the surgery, whether the disease was salvageable with surgery or not. They basically concluded, or rather I would say presented RPA classification, in which they have refined the patient selection on the basis of 3 things, that is the interval, the resectability status, and the organ dysfunctions. So all the patients who at the time of re-RT had a disease-free interval of more than 2 years, and their disease was resected, were classified into class 1. And these class 1 patients has an overall survival of 62% at a median follow-up of 48 months. And when we talk about all those patients, when the interval was less than 2 years and they had an existing organ dysfunction, they were classified as class 3. And this RPA class 3 population had an overall survival of only 16.8%. The patients who had an interval of more than 2 years, but the lesion or the recurrence could not be resected, they were classified into class 2. And similarly was for the patients who had no organ dysfunction, but the interval was less than 2 years. All those patients were classified into class 2, and they had overall survival of 40%. Now coming towards the discussion of the RT volumes, RT doses, and fractionation in the second course of RT, in the re-RT scenario. So this is a famous paper which was published in the year 2009 in IGROBP. They have described the patterns of failure after re-RT of recurrent squamous cell head and neck carcinomas and their definitions of the targets. This again was a retrospective study. All the patients from 1994 to 2007, which was a total of 66, and had a median prior dose of 64 gray and a median interval between both RT course of 37 months and a median re-RT dose of 68 gray. And this is the range of the re-RT. Of these patients, 54% received RT conventionally, and 46% has an accelerated hyperfractionated regime. The cumulative radiation dose given was 129.2 gray, and the target volume was basically the RGTV, which is a recurrence GTV with a 0.5 centimeter margin. Although in literature, these margins are heterogeneous, ranging from somewhere from 5 mm till 2 centimeters somewhere. Chemotherapy was given to 71% of the patient with 2-year local recurrence of progression-free survival of 27% and overall survival of 40% for a median follow-up of 42 months. So when they retrospectively analyze these patients for the patterns of failure, please mute yourself. Okay, so the patterns of failure was 96% of the patients failed in this RGTV, which is the recurrent GTV side, and 4% of these of the patients failed outside. Despite, and this figure 96% failure in RGTV was despite the fact that the prophylactic re-RT of the nodal basins which were at risk was omitted. Even then, the disease did not fail in these nodal basins which were at risk. In fact, it failed in the primary, that is a gross site. These are some other curative studies which are summarizing the target volumes. The famous studies by the Spencer and Salama et al. By Nancy Lee. All these studies have, as I mentioned, different methods of contouring the target volume, and it ranged from 0.5 cm margin to a margin of 2 centimeter. This is comparatively a recent publication. It was published in the year 2018 in IGROBP by Jimmy J. and Matthew C. Ward. Patients were, there were 505 patients with a performance status of around half of the patients with a very good performance status. Patients with poor performance status were very less in number in this population. 75% of the tumors were recurrent, and around 25% were second primaries. Stage was very variable. There were all stage patients, which are stage 1, 2, 3, and 4, with different nodal categories at the time of recurrence, and a median follow-up of 21.5 months, which isn't very much. Now, if we look at the radiation techniques employed, it was IMRT, right? In some patients, the IMRT was done in the definitive setting alone. In some, it was done alongside systemic therapy, while in some patients, it was done in the adjuvant setting. If we look at these stats, majority of the patients were either treated with IMRT and chemo, that is chemo and RT, and the second vast majority was adjuvant RT, who had no gross evidence of disease. The dose which was given was 60 to 65 to 95 patients, and over 66 day in 88% of the patients. There was also a subset who received elective neck radiation. Even there was a subgroup of the patient who were node negative, but they delivered elective neck RT. And we will see in the upcoming slide that there was no added benefit of doing so. And here it is. elective neck RT, which they did in the node negative patient, there was no added benefit of doing elective neck RT than just omitting it. Elective neck radiation in node positive patient, even then there were no statistically significant differences in doing it or just omitting it. All right. So now overall survival by dose. We can see over here that the population of patients who received 66 gray did better. We can see over here. Although the result is not really statistically significant, but these were probably the population of the patients who had no other factors that progressed them towards the death. That is, these are the patients who probably had a very good performance status, no baseline organ dysfunctions, that the clinicians opted to deliver a higher dose. Similarly, you can see over here, this is also a slide which is showing the graphs for radiation doses in the definitive setting. And these are the different fractionation regimes. None of the regimes were superior to the other, signifying that the conventional, that any other regime other than conventional is not providing any additional benefit. Similarly, the fractionation in the post-operative setting. Now let's just summarize the results. So there's still, again, there is no consensus, but any dose that is, as we discussed in the definition earlier, any dose which is a 2 gray equivalent of at least 45 or above, that is at least 50 or above, is necessary to achieve a substantial response. However, most investigators and groups have used 60 gray as a target Re-RT dose. Gross disease, you may escalate till 70 gray or 266 in post-op setting, but this has to be a very careful selection. Re-RT dose to spinal cord is 10% of the prescribed Re-RT dose, and there is no difference between the conventional versus hyperfractionation as we just saw in the previous curves. Now, talking about the technique, there was a recent Canadian survey on Re-RT, not really recent, it was published in 2008 by Korean Jones, by Joseph et al. In IGROBP, that the most desirable, according to this survey, the most desirable for Re-RT is the brachytherapy technique because it probably allows you to deliver the higher radiation dose with better sparing of the OIR. So with the availability of advanced imaging modalities like PET and MRI, and when you have an option of IGRT, hyperfractionation may also be a feasible modality, but there is no established consensus. Now talking about the modalities, the highly conformal the modality, the less is the normal tissue exposure. That is, the more conformal modality you will use, the better you can spare the OIRs. And here comes the role of the expertise and the infrastructure as described by these 3 M's, which is man, machine, and methodology. The expertise, that is the comfort of the radiation oncologist with any technique, the patient preference, and the availability of techniques is what plays the role in selection of modalities. Okay. Any question till now? All right. So this one is from IGROBP 2016, which is re-irradiation of head and neck cancer with IMRT. These are the outcomes and analysis as published by Take Care et al. It was basically an MD Anderson experience, again a retrospective study with 227 patients. The primary endpoints for overall survival, progression-free, local regional control, and distant met. Please mute yourself. All right. So a median dose of 66 gray was delivered, and the target volumes were like GTV was given a margin of around 8 to 15 mm for CTV, and then a further margin of 3 to 5 mm for PTV. There was no elective nodal RT, and the technique utilized was IMRT as it is written in the title of the study. All the recurrent and second primaries which were treated with IMRT were included, and all the patients with distant mets were excluded. Around 73% of these patients of Re-RT received chemotherapy, of which 67% was concurrent platinum. Intent was adjuvant in 46% of the patient, while in cases of pharynx, it was delivered in a definitive setting. Now, these are the clinical outcomes as per the histology. And this is the toxicity analysis. And it shows that re-irradiation with IMRT, whether done in a definitive setting or after the salvage surgery, provides a promising local control and survival in a selected group of patients. Patient selection is very crucial, as we discussed in the initial literature. Treatment-related toxicities, however, remain significant, provided that the patient also received a first course of full dose RT followed by another tumoricidal dose in the second course of RT. These are some of our responses to take care at all for re-RT of head and neck cancers, and specifically for nasopharyngeal carcinomas re-RT to the NG et al. Now, these are two very famous RTOG trials, RTOG 9610 and
बेटा
RTOG
थोड़ा
999.
सा एक मिनट थोड़ा सा आप तेज जा रही हो पीछे
जी
जाए ना
सर.
एक स्लाइड वो हमारा वो कमेंट बहुत इंपॉर्टेंट था क्योंकि दैट रिफ्लेक्ट्स द पाकिस्तानी प्रैक्टिस जिस पे दे हैव टू आंसर इट ना दिस वाज एक्चुअली आवर क्वेश्चन टू देम व्हिच वी पुट फॉरवर्ड अब इसका आंसर भी बताइए ना उन्होंने क्या दिया था मैं
All right,
बता
so
देता हूं बता दूं
हाँ जी सर.
आप बता दो
Okay, so
so what
these
was the answer
are basically two comments that we made. One was for the re-RT in head and neck, and one was for re-RT in nasopharynx specifically. This particular
yes
paper was by Take Care et al. And we basically asked the authors to comment on that what proportion of their patients had a positive HPV status, which was not identified in the published paper. And second, we asked them what did they happen to stratify the outcomes of the HPV positive and negative patient? And third was a separate analysis for the NPC patient, provided that NPC has a different necessity as compared to the usual squamous cell of head and neck. All right. So, and in the other paper, which was regarding the nasopharyngeal carcinoma re-RT, this was by NG et al. And it was published last year only. In this as well, we asked the authors to give a reference for the DFI or a stratification that would enhance the understanding of the radiation oncologists who would refer to their paper. And second, we also asked them to correlate their findings with respect to spinal cord, as it is one of the very critical organ at risk when we are radiating the nasopharynx. So these were our queries with the authors.
ठीक है अब आप आगे बढ़िए तो मैं लास्ट में कमेंट्स में मैं थोड़ा इस पे ऐड कर दूंगा ठीक है so please move forward mashallah you are doing very well mashallah
All right, so these are the two RTOG trials, RTOG 9610 and 9911. These papers were published in the year 2007, and there were some differences, very few differences in both these papers. The re-RT schedule was 1.5 gray BID to a total of 60 gray. The margins were tumor with a margin of 2 centimeter in both the studies. The RTOG 9610 incorporated 2D and 3D techniques, while the results published by 9911 incorporated 3D and IMRT. The concurrent regime in the 9610 was 5FU, while in 9911 it was cisplatin. And the 2-year overall survival was 15% and 26%. So if you look at the survival curves, they are somehow the same. Now coming towards this, this is that publication from IJROBB 2018. Again, this is from that MIRI collaborative regarding the comparison of SBRT and IMRT for definitive re-RT of recurrent or second primary cancers. If you look at the comparisons, the overall survival are somehow the same in RPA class 3 patient, the RPA which were defined, the RPA classes which were defined by the MIRI collaborative, and we have already discussed that. But in the subset analysis, they saw that in the RPA class 2 patient, there was a subset of patients who did well with SBRT, although the results were not really statistically significant. But this particular subset was that who had a tumor burden of or a tumor volume of less than 25 cc. So perhaps patient selection, when the lesion is very small or the GTV volume is less than 25 cc, perhaps these patients can benefit from SBRT. while respecting the dose content and looking at the anatomic location of the disease if it is not lying in very close proximity to the to a critical structure despite its low volume as well. So if we conclude this study, Re-RT both with SBRT and IMRT appeared relatively safe with a favorable toxicity compared with the historical studies, but outcomes vary as per the RPA class, which was initially defined by the Miri collaborative, and then they published further comparison of the SBRT and IMRT. So survival by both the modalities, whether IMRT or SBRT was incorporated, was poor in the class 3 patients. So this is particularly about the role of post-operative Re-RT in recurrent and second primary cancer. It was a literature review, and the answer was that the indications of post-op RT, which was included in their review, which they published, a highly conformal technique when you are doing Re-RT. Always consider a dose of more than 50 gray because that would somehow produce some biologically meaningful effect. Otherwise, doing half-hearted radiation would do no benefit, in fact, create more toxicity. Local control, as per the published literature, is quite variable with a 2-year overall survival of around 48%. There are multiple degrees of toxicities like mucositis, dysphagia, late fibrosis, pharyngeal dysfunctions, and even death in some of the patients. So post-operative Re-RT, the data shows that when Re-RT is done after surgery, it does improve the local control, but there is no such impact on the overall survival. The GTAC or the GORTAC 9803 study, which somehow closed its accrual quite early, showed a trend towards improved progression-free survival. The selection criteria was again positive margin, PNI, LVI, and ECE. This here is giving us a message that the indications of adjuvant RT remains the same, whether it is the first course or the second course. The main challenge is the patient selection, always with concurrent chemo whenever possible. So there are some long-term complications of Re-RT schedules, which as per 9610, which is a famous RTOG trial, acute grade 2, grade 3 toxicities were over 40%, but we need to, as we just discussed, go back and see that half of these patients were treated with around 2D RT. Late complications were seen in 12%, while death occurred in 8% of the patients due to the complications of Re-RT. Similarly, the RTOG 9911, grade 3 to 4 toxicities were in over 45% of the patient. Some amount of patients do develop cervical fibrosis or osteoradionecrosis, trismus, and carotid hemorrhage. Now, this is just a review. You can go back to this paper. This was published by a Korean Radon group in the year 2017. This gives an overview of the patient selection of the treatment paradigm and the flow of how to go about it. And this is the very recent, we discussed this today as well, very recent, published earlier this year in IJROBP regarding the executive summary published by the American Radium Society. So it is definitely going to be a good read. Do give it a read. Now coming back to the case which we discussed earlier, I have tried to cover the pertinent literature to guide you towards deciding or have a fruitful discussion on how would you treat this patient. But before we proceed, I would like to ask the attendees, do you think there is some information missing? As this is a hypothetical case, we do not have any imaging available, any representative images available for this, but I have missed one parameter that would guide us in defining the treatment paradigm. Can anyone comment that what have I missed in this?
HPV status.
Do you think it is going to guide our treatment intent or the doses?
Dr. Maria, I would like to add something.
Gigi.
So the previous OAR doses and what was the modality previously used for treating the patient in terms of RT technique, and what were the doses prescribed, and specifically our major concern in this scenario would be the dose to the spinal cord and all the important structures around for which Dmax is important.
All right. So in short, if we say the whole of the RT details, and that would include the RT sequela as well. That is there any existing late complication that the patient is living with? And obviously the RT details. So the radiation details are missing in this.
Sorry for interruption. Sorry. I'm very sorry. भाई वो 5-6 लोग पूछ चुके हैं, उनके पुराने रेडिएशन की डोज तो बताओ कितनी थी? वो तो शुक्र है कि ये फिजिकल नहीं हो रहा, वरना ये लोगों ने अंडे फेंक देने थे अभी तक. 5-6 लोग पूछ चुके हैं भाई. बताओ ना पिछली रेडिएशन की डोज कितनी थी इसकी? वो बड़ी इंपॉर्टेंट है शाबाश. चलो बता दे.
So this is a hypothetical case. We are going to from now on we are going to keep the discussion totally interactive. May I please request Dr. Fatma to join us and drive the discussion?
Can we assume that this patient has 66 gray with 2 gray fracturation? हम assume कर लें फिर ये?
Yes, sir, exactly.
Assalamu alaikum. Ji sir, this patient was seen by me in the clinic, and this patient basically received 66 gray and 33 fraction at 2 gray per fraction. So this was the total dose received by this patient, and bilateral neck was radiated. Now currently he is presented with lesion in the piriform fossa. At this moment, his performance status is really good. He was eating orally. PEG tube was removed after 6 months of radiation. So I sent this patient to the surgeon for evaluation of any tracheostomy tube required before radiation, and also for the surgical evaluation. So this patient was evaluated by surgeon, and tracheostomy tube was not required, but his mouth opening was limited, and he's planned for gastrostomy as on local anesthesia on Monday, and he's booked for simulation also.
All right. So how would you treat this patient?
So
स्टेज तो बताएं आप. देखें सबसे पहले स्टेज तो बताएं ना. You have a relapse. So what is the size of the tumor? I have a patient who had radiation done 40 years ago. She's 70. आप उसको एग्जामिन करें, आपको लगता ही नहीं है कभी इसको शुआएं लगी हैं. अगर आप उसकी हिस्ट्री को डग आउट करें तो वो कहती है मुझे 15 दिन शुआएं लगी थी मोल से, इरनम से. अभी आप उसको MRI कराएं तो आपको उसकी जो लेफ्ट साइड की मैंडिबल है वो सारी उसमें रेडिएशन इंड्यूस चेंजेस हैं. तो हमें लगता है कि उसको फुल डोज रेडिएशन मिली हुई है. उसकी जो डिजीज़ है वो इसी तरह से टॉन्सिलर फोसा में है. इट्स गोइंग इनटू द बेस ऑफ टंग. शी डजंट हैव एनी एडिनोपैथी. वी सेंड हर फॉर अ पेट स्कैन. बट द क्वेश्चन इज कैन यू अगर आपको डिजीज़ का साइज ही नहीं पता, तो अभी आप जैसे कह रही थी कि SBRT आप 25 cc से कम के लीजन को दे सकते हैं. ऑल्दो we should look at the subgroup analysis very cautiously. They are not the end point of a study. आप उसमें से बहुत ज़्यादा infer नहीं कर सकते. But if you do not have data to support what you're doing, sometimes subgroup analysis give you an insight. तो पहले आप इसकी स्टेज तो बताएं ना. जो भी ये नया रिलैप्स हुआ है, इसका साइज क्या है, हजम क्या है, फिर हम आगे चलते हैं.
Okay, so currently the lesion in the piriform fossa is 3 into 4 centimeter, and there is no lymphadenopathy visible on the CT scan and as well as on palpation. PET CT is not done because the patient is not affordable, and here at JPMC PET is not working. So we advise him to get CT head and neck with chest, and it's clear. There is no metastatic deposit.
तो दूसरा सवाल हमारा ये होना चाहिए कि रिस्क बेनिफिट रेशियो एंड क्वालिटी ऑफ लाइफ, जो डॉक्टर साहब ने इतना अच्छा लेक्चर हमें प्रेजेंट किया, इट इज़ फुल ऑफ डेटा एंड लॉट्स ऑफ एविडेंस. तो हमारा सवाल होना चाहिए, व्हाट डू यू थिंक योर रिस्क बेनिफिट रेशियो tilts towards surgery, or do you think it tilts towards re-irradiation?
Definitely in re-irradiation, the first thing which we should evaluate in every patient is salvage surgery. We should send the patient to surgeon to know about is
No,
there
we know
any
that.
possibility.
We know our data. What I'm saying is आपका ये पेशेंट है तो आपने सर्जन से कहा कि surgery is going to be superior because a piriform sinus tumor which are relatively
Surgery will result in too much morbidity in this patient, and this is the reason this patient is booked for
so
re-irradiation
the
with
patient
concurrent chemo.
refused the morbidity of a major surgery and pull up
Yes.
procedure. So that's why you're talking about this patient regarding re-RT. So it should be very clear in mind what is the patient's choice. हम तो री-रेडिएशन की भी तो कम वो नहीं है ना, आपने पहले रेडिएट किया, आप दोबारा 6000 के करीब देंगे, तो 12000 के बाद अगर रिलैप्स हुआ तो क्या फिर उस वक्त सर्जरी हो सकेगी? हमें आज ये सोचना होगा ना, 2 years down the line. तो हमें ये चीज़ें अभी से सोचनी है एज अ ट्यूमर ग्रुप कि ये चीज़ें हमारे जहन में होनी चाहिए. सो patient choice would veto any tumor board. I agree with that. So if he doesn't want, it's fine to go ahead with radiation.
Thank you, Dr. Farooq. So any other question do we have from audience?
So what kind of fractionation are you going to use? Are you going to use the last slide which you just showed? The RTG trial? What fractionation are you going to use?
Yes, we're going with the conventional radiation, and we'll go with 2 gray per fraction regime.
200
this patient
per
will
day?
be, yeah.
You'll go for 200?
And this patient will be treated on tomotherapy with conformal radiation. And we have asked the patient to bring the radiation record and all the OR doses. We have requested the previous hospital to provide us with all the radiation records so that we can discuss with the planner and control our OR doses in this current plan.
Right.
And it will be given with concurrent chemotherapy.
It makes sense. Is there anything different you're going to do for this patient apart from spinal cord? Is there any other organ at risk near piriform place?
Other organs which are concerned for me are parotid and mandible.
Yeah, I think carotid is the most important part because the data suggests you got very high risk of a carotid rupture. Nadeem is there. So I've been re-irradiating these patients who've been treated elsewhere, like Shaukat Khanam and like Agha Khan. We have a tertiary care center equipped with this IMRT and above and IGRTs. We do not have brachy. So I have done it, Nadeem, with 150 BD. I do it for 1 week, then a week rest, and then 1 week, and then a week rest, and then 1 week, and then 1 week rest. So to go 150 twice a day for 5 days makes it 1500. So we do it over 8 weeks. Very, very tolerable. The risk of delayed consequences are very low. But what I've seen in my practice is the quality of life of these patients is really miserable. मुंह बिल्कुल उनका tasteless हो जाता है, xerostomia होता है. So yes, they live, but they live at a cost. So coming back to your discussion, which you started, I think beyond tumor board, the patient should sit and be part of the discussion. कि जब वो ये डिस्कस करता है कि कौन सी मॉर्बिडिटी वो खरीदेगा, रेडिएशन की या फिर सर्जरी की, everything has its own risk benefit ratio. So honestly, Nadeem, I'm always confused being a spokesman for the patient कि मैं उसको किस तरफ लेके जाऊं, सर्जरी की तरफ जहां वो बोल नहीं सकता और उसको शायद tracheostomy chahiye ho, which is very morbid, and we take the lead over there that we preserve the functions and anatomic integrity of the tissues as well as quality of life, या फिर हम उसको re-RT की तरफ लेके जाएं. So I totally agree that this needs to be discussed in a valid group of clinicians who deal with this entity, और इसमें dietitian का होना, nutritionist का होना, and I think patient ka part and parcel hona in decision making is very, very integral. As I said, that I have few objections on these data. हम बड़े आराम से कहते हैं 45 ग्रे कम से कम होनी चाहिए. Do you imagine 45 gray in any way a dose that would be tumoricidal, other than if I remember when I started my career like you, कि हम occult disease के लिए जो neck में होती है उसमें 45 ग्रे देते होते थे ऑफ कॉर्ड करके जब हमारे पास 2D होता था. उसके बाद से आज तक तो मैंने 45 ग्रे कभी यूज़ किया नहीं है SIB IMRT में या कहीं भी. तो I'm no authority to say, but I think that's obnoxious. किसी को भी अगर आपने re-RT करनी है, think about the tumoricidal dose and nothing less than 60 gray. Either you do it as a conventional fractionation or the fractionation, which is again one of the RTOG trials, जिसमें 150 BID देते हैं, 4 days a week भी देते हैं, week का rest भी देते हैं. So 45-50, I'm not for it. देनी है तो पूरी देनी है. सर्जन से मैं कहूँगा अगर सर्जरी तुम पूरी कर सकते हो.
Dr. Farooq is very right, and I fully agree with him. 45 is no more a dose, but it was used in the past, of course.
Agreed.
हमें थोड़ा सा जो इस पे ध्यान देना है ना फारूक भाई, वो जो हमारी प्रैक्टिकल नॉलेज बड़ी ट्यूमर बोर्ड के बाद से वो हमने बहुत लर्न किया, और अनफॉर्चुनेटली वी लर्नड इट द हार्ड वे. हमने बड़ी मुश्किल से लर्न किया और अभी भी लर्न कर रहे हैं, अभी तक लर्निंग कर्व में ही है. वो बड़ा ही खतरनाक हमारी फाइंडिंग्स आ रही हैं. उसमें क्या हो रहा है कि वो रिकरेंस है ही नहीं, वो रेजिडुअल है. जैसे आपने शुरू में भी कहा था, वो रिकरेंस नहीं है, वो रेजिडुअल है. तो आप जो है एक काम ये कर सकते हैं हम कि मेरी लास्ट स्लाइड जरा दिखा दें, तो मैं इजाजत लूंगा कि 4 बज गए, मैं एक जगह कमिटेड हूँ. तो उसको फिर आप डॉक्टर फारूक हमारे सीनियर है, मैं बड़ी इज्जत करता हूँ, बड़े अच्छे हमारे कुलीग है. इसके बाद की स्लाइड में ये देखना है कि हमें जो है, हाँ बस लास्ट इसके बाद वाली ले लें, कि हमें ना इसका मसले का हल निकालना है, और ये हमारा अपना मसला है, लोकल मसला है. तो इसमें आई थिंक वी हैव टू रिपीट द होल डोज विद जीरो कॉर्ड. इस पे मैं बहुत ज्यादा एम्फसाइज करूंगा कि जीरो कॉर्ड, क्योंकि अनफॉर्चुनेटली दिस इज एविडेंस बेस्ड नंबर 4. तो ये 4 है. हाँ मैडम, मैं आपसे मिलने आ रही हूँ. तो इसलिए ना आप अगर ये बुलेट नंबर 2 पे हम सब एग्री कर जाएं, नेशनली सब लोग अवेलेबल हैं, इस्लामाबाद से भी है लोग, लाहौर से हैं. So I think that would be the take-home message for all that effort with Maria and colleagues and Fatima has done. तो मुझे इस पे अगर आप बुरा ना माने तो इजाजत दीजिएगा इस बुलेट नंबर 2 पे, और मैं डॉक्टर हमारे फरूक will take over from there. ठीक है, तो अल्लाह हाफिज from my side, but I think this is a take-home message from my humble point of view. और इसको जितना जल्दी हो हाजी किप्रो के अंडर में कायम कर ले प्लीज. ठीक है, जज़ाकल्लाह. अस्सलाम वालेकुम.
Assalamualaikum Nadeem. दूसरा मेरा एक concern is always re-radiating with concurrent chemo. Wow. I mean, again, आपका patient मुझे बहुत अच्छा लग रहा है, 40 years का, you know, is just like a 70 years old man, which is usually mentioned it, 72 kg man, which is a typical man, healthy man. तो जो ये patients होते हैं, they are, they have had their battle of मैं क्या कहूँ कि they have had full treatment, surgery हुई होती है, radiation लगी हुई होती है. मेरे जो patients हैं, plastic surgery हुई होती है. They have a tongue, but they cannot swallow the way a normal person can. They can't taste, they do not have anything that produces enough mucus there. तो हम इस किस्म के चीज़ों की बात कर रहे हैं जो ऑलरेडी मॉर्बिडिटी में से गुजर चुके हुए हैं. तो हमारे पास इस तरह का 40 ईयर वाला मेल अभी तक आया नहीं है. आई थिंक आप लोगों ने भी मुझे यही बताया कि प्रॉब्ली दिस इज अ मेड अप केस. तो ओके, इफ यू हैव सच केसेस, यस वी कैन डू इट. नॉर्मली दीज आर 67 60 इयर्स 70 इयर्स. आवर बायोलॉजी इज डिफरेंट. मेरी नज़र में तो जितने भी मरीज मैंने री-रेडिएट किए हैं, शायद 1 साल से ऊपर मैंने उनका फॉलोअप नहीं देखा. And I presume that they have died or they have become moribund or something. So yes, I agree with Dr. साहब कि हम ऐसे पीस मील लेके अगर 3 महीने किए हैं, चौथा मैं कर रहा हूँ 8 सालों में, तो फिर हो सकता है कि आप कुछ लाहौर से पकड़ लें, कुछ पेशावर से, तो हमारे पास एक सीरीज बन जाए and we can actually see what is going on in our subjects. सर, क्योंकि ये तो आपको पता है ना कि जो हमारे कैंसर्स हैं वो बीटल नट, नस्वार, पान, और हमारा इज नॉट दिस Virus is not a problem of Pakistan usually. I don't know about the trend in Karachi, but हमारे यहाँ पे it's not very common here. तो हमारा पान नस्वार गुटका is more common. बाहर के मुल्कों में HPV and alcohol and cigarette is much more a problem. तो हमारी biology different है, उनकी different है, हमारी tolerance different है, और उनकी different है. Yes, for your patient, which you presented, I agree if it is only 2-3 centimeters, 3.5 centimeters, anything less than 50 cc can be salvaged. I worked in Hull for 6 weeks, 2014. वहाँ जो वितोरी काम करता है, he is from Belgium. This guy works only in head and neck. तो वो कहता है anything 50 cc or below is mine. I won't let the surgeons do anything about it when it comes to quality of life. तो ये सारी चीजें आप अपने जहन में रखें जब आप re-radiotherapy कर रहे हैं. And I'm very glad that you have taken this initiative. And Maria, you've done a wonderful job presenting this wonderful presentation, a lot of data, a lot of inferences, and probably I also learned from there the lymphatics are sterilized from the first radiation. There's no very limited, if any, disease comes back in the lymphatics. Or last but not the least is के आप कहते हैं recurrence versus residue. Can anyone define between recurrence and residue? Any of the students or colleagues?
Residual disease, if we are doing the CT scan after 3 months, and we can found that there is a there is no there is no completely response.
All right, no, that's fine. I agree, but is there a timeline? Oncological timeline. I don't know if things change so fast that you have to run with the medical education. So I can refresh it. When I learned it, anything that remains there and picked within 6 months is residue. Anything that comes out, pops up again after the 6 months timeline is a relapse. So residue कहना 4 साल के बाद would be very unfair with all the apologies. It does not, we know there is a second primary within the field. और जो आपने बहुत अच्छे तरीके से बताया भी, I'm really pleased. But I think that should be kept in mind that these are second cancers. And as the data suggests, 15% in first 5 years, usually that's the incidence. And they may occur there, or you may have synchronous primaries as well. The synchronous primaries sometimes do not occur in the same area. And there you're lucky कि आप overlap से बच सकते हैं. Reconstructive surgery sometimes help you a lot. सारा tissue निकल गया, mandible निकल गई, segmental mandibulectomy हो गई, neck की chain सारी निकाल दी, नया tissue लगा दिया, अब relapse होगा तो you still have chance to re-radiate, so that is also kept. लेकिन मेरी practice में जो मैंने सीखा है, like Nadeem, I have been practice since 31 years, और hardcore head and neck over the past 8 years. अभी मैंने छोड़ी है, I'm into other avenues of oncology. आते हैं मेरे पास अभी भी मरीज, लेकिन पहले 5 साल मैंने I've done so many of the head and neck, the core of head and neck. I think if the surgeon cannot give you a negative margin, I wouldn't vote for a resurgery. That's what the take-home message is, because I am limited by my radiation dose. मैंने किसी को 2 साल से ऊपर जाते देखा नहीं है, और जिनकी भी surgeries हुई हैं positive margin, I don't think we have achieved anything in them. They're more like palliative surgeries. Thank you very much. Thank you for giving me time. It was wonderful to learn from you.
Thank you, Dr. Farooq.
So we can close the meeting if there's nothing else.
Excuse me, I have just one question. Can you please repeat regarding the lymphatics that you said? Are we supposed to radiate them prophylactically during the first radiation dose, or are we not supposed to do that? I didn't get it.
Dr. Saab said you don't have to. because lymphatics is the area of radiation oncologist. आप वहाँ शुआएं लगा दें, अगर सही dose दी हुई है, the chance of a relapse in irradiated neck is very, very low. That's what she was saying, peripheral areas, no? The chance of a relapse is less than 5%. Most of the recurrences is in the high dose area. That's what she said precisely. So we do not have data, evidence to re-radiate lymphatics. Yes, if you got highly rich lymphatic organ like the piriform sinus or the oropharynx or the base of tongue where the relapse is there, you're always, prompted to radiate the first echelon. But then again, the carotids are there. You're taking a risk. Now, since she has shown evidence, I think we shouldn't be radiating it. We should not re-radiate an irradiated neck when tumoricidal dose has been given there before. और कभी भी ऐसे लगे कि हम full dose radiation नहीं दे सकते, तो please be brave to tell them we can palliate 30, 20. सिर्फ उतने से वॉल्यूम को जहाँ है वो भी आपको 6 महीने अच्छे दे देगा. Don't worry about it. That's what I learned over past 9 years.
Sir, I'm totally agree with you. I'm working in Saudi Arabia, King Fahd Medical City. It is one of the biggest center, and we have a lot of re-radiations in the head and neck, and we never radiate the neck. Always we are giving, if there is a re-radiation, we are our focus is
दूसरा एक और भी याद रखें ना कि एक टाइम लाइन और भी है जो 2 साल के अंदर रिलैप्स कर देते हैं. जो 5 साल के बाद करते हैं ये तो बड़े अच्छे हैं. जैसे मेरे पास एक अभी आई हुई है खातून 72 इयर्स की, उनको 40 इयर्स पहले बक्कल मिकोजा को रेडिएशन लगी. तो 40 इयर्स तो बहुत अच्छा टाइम है. टिश्यूज भी भूल गए हैं जख्म अपना. But we have still to be careful. What about patients who relapse within 24 months? वहाँ पे ये जो 150 BD वाली डोज है ना, that is what I was mentioning, कि वो ज़्यादा सहल है. Hyperfractionation is much better than conventional based on an RTOG trial. Much more tolerable, and the side effects, delayed side effects, are not as many. None of my patients had. But problem वही है कि हमारे यहाँ उतना meticulous follow up नहीं है. वो 1 साल तक आते रहते हैं, फिर अचानक गायब हो जाते हैं. So less than 2 years, again, a major challenge. Something that occurs beyond 2 years, again, that's something relatively easy, I would say. तो इससे हमने घर take home message क्या है? Don't just throw your radiation and then forget them. The most precious patients are who are treated in a definitive way, curative way, जिनकी surgery हो गई, plastic surgery हो गई, आपने शुआएं लगा दी, उनका surveillance plan आपका बहुत stringent होना चाहिए. You need to guide them that, okay, you're disease free, but we do not guarantee. There's a 15-20% chance you may have a relapse here, or you can have a synchronous primary. So we need to follow you with meticulous clinical examinations, both by the oncologist, the ENT, or a MAX-FAC, and an MRI. Nothing less than that, or a CT, whatever. तो ये ऐसे कैसे हो जाता है कि मरीज जो है वो गायब हो जाता है और फिर उसका इतना बड़ा ट्यूमर आता है वो बेस ऑफ टंग में भी जा रहा है. Obviously when they lose follow up. So the take home message is pick them early and treat them early. That's how you should do it.
All right, sir. Thank you so much for your valuable input. We are already ahead of time. So I would like to conclude the session by giving these acknowledgements. Dr. Asim Hafiz was with us a short while ago, but I guess he is not connected now. So a huge thanks to Dr. Asim Hafiz for all the scientific content. He helped me a lot in making this presentation. Dr. Nadeem Abbasi, Dr. Farooq, Dr. Fatma Shaukat, Dr. Hamad, and Dr. Batul Nusrat for recording this session. So thank you.
Thank you, Betty.
If
And
there is any more question, you can ask. Otherwise, we'll be
only there is a vote of thanks to you. 3 of my postgraduate residents are also listening to you, which is Shifa's residents. So we have joined you. So don't forget them.
Yes,
in
sir,
all
I know
your
them
future
well.
endeavors, and we'll try to उनको भी शामिल करेंगे इसमें वक्त के साथ. They are very young, and inshallah with time they will be part of your team as well. Thank you very much. Excellent work.
Yes, I'll be very happy to include And thank you so much, sir. And this is an open invitation to all the attendees. Whoever wants to come up with a case-based discussion, they are more than welcome. I have been conducting these sessions, but I think that other attendees would also participate as leading the session. So I will be more than happy.
Thank you, Maria. Thank you, Dr. Farooq.
Thank you, everyone.